Oh, I know it's a little bit challenging. I think first off, I think it really depends on the definition of disease modifying. I think we know with ruxolitinib, as much as we're talking about leveraging novel combinations and different things, ruxolitinib is very effective for many patients. It's able to drastically reduce their spleen volumes, improve their symptoms, really give them a life that they have back. And we even know that it has a survival benefit. And the question is that really disease modifying? I mean, it is for many patients. It would be counterintuitive to say that we haven't modified someone's disease when we've drastically improved how they feel and some of the objective signs. But unfortunately, when we look in the marrow, we still see disease. When we look for mutations, we still see mutations. And so we're not getting remissions, right? We're not eradicating the disease per se, even though we are probably modifying it. And I think there's many reasons why we're not able to do that. I think right now we don't have, mutation-specific inhibitors of JAK2. We're inhibiting wild type and mutant JAK2, and you can't inhibit wild type JAK2 too much because you need it to make blood cells. And so, I think we need to develop, more mutation-specific inhibitors. We need to leverage the immune system and think about maybe early intervention. Perhaps, intervening for only higher risk myelofibrosis is just too late in the game to really do anything meaningful. Most of those patients have multiple mutations, and we know that that's a challenging disease. But I think, if anything, we're seeing great basic science abstracts here. We know the work's ongoing, and that's really where things start. We understand the key kind of core of the disease, the root of it, and then we establish targeted therapies to go after those diseases and see if we can actually make some meaningful differences.